Angel, will you let me know when I should get started?
Hello. Welcome to the University of Toronto Joint Center for Bioethics Seminar Series. I'm Angel Petropanagos, and I'll be the moderator for today's session. Our speaker today is Vivian Tam, and her seminar is entitled Evaluating the Toronto Region Hospital's COVID-19 Visitor Policy Using an Accountability for Reasonableness Framework. Before I introduce today's speaker, I'd like to let you know that the seminar today is being recorded. This lecture, along with other archived lectures, can be accessed through the Joint Center for Bioethics website. And the format of our seminar is a presentation by our speaker, followed by a facilitated discussion period. To begin, we wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and Mississaugas of the Credit. Today, this meeting place is still home to many Indigenous people from across Turtle Island, and we're grateful to have the opportunity to work on this land. Now, it is my pleasure to introduce you to today's speaker. Vivian Tam is a family medicine trained emergency medicine resident at the University of Ottawa. She completed her family medicine residency in the integrated 3-year leadership program at the University of Toronto, where she earned her MSc in system leadership and innovation. She has a career interest in health equity and the design and implementation of systemic interventions that help to achieve this goal. Well, Vivian, welcome, and I'll turn it over to you.
Thank you so much, Angel. And so thank you everyone for joining me virtually today. We are going to be discussing our quality improvement project on evaluating the Toronto Region Hospital's COVID-19 visitor policy using accountability for reasonableness. Before we get started, I'll just have to apologize. I didn't expect to still be in the hospital at this time, but here we are. And I wanted to thank you again for taking the time out of your schedule to join us virtually here. Given all of our competing interests, particularly nowadays, I know that there's a particular reason that you decided to join this session. And so what really interests me about this work is that at this point during the pandemic, most all of us have been impacted by a COVID visitor policy, whether interacting with it in the capacity of a healthcare administrator or frontline worker, or as a member of the public or family member, even patient yourselves. And so before we get started, I would be really interested to know what capacity you've interacted with the COVID visitor policy in. And so if everyone could take a minute to navigate to the poll everywhere that I've set up, and you can either navigate to that web link or just text this phrase to that number here. I'll give everyone a few minutes to do that if you're willing and able, and if you're not, I would ask you to at least ponder the questions that we'll be going over in the next couple of slides. I'll just leave this up here for a minute. And the first of the questions that I'm hoping we can answer together is this one. So in what capacity have you yourself interacted with the COVID inpatient visitor policy? I think I just have to activate this poll, so I'm going to be doing that. And it should be active now. And so I'll give a minute for our results to roll in. And so reviewing what we've said so far, I see that some of us have helped to develop these policies, equal numbers between developing, implementing policies as a patient and family member, a good number of us who are just curious about what this process has looked like, and then for some of us, none of the above quite fit. So as our discussion has moved forward, it looks like many of us are curious about what this policy may be like. And it looks like our responses are settling out. Fantastic. And so these responses will really help me tailor the rest of the discussion that we'll be having. So thank you for doing that. And then my second question for you is, I'll flip over here. What has your experience been with the inpatient visitor policies you've interacted with? And so for those of us who haven't really interacted with one, this can be what you've heard, even what you know of family members or loved ones who might have been in hospital and who may have actually needed to interact with the policy themselves. And so I will activate this question. And really, these can be broad-ranging thoughts. So if we think that it was justified to have a COVID visitor policy in place, whether they seemed fair so far as we know, whether they were unfair, etc. So some of the responses that stand out to me so far are heartbreaking, confusing, both justified and unfair, labor, which I think is a very interesting response, and we'll talk a little bit about that. Some understandable, some unfair, some inflexible. And so a really broad range of responses as to what our experiences have been with the visitor policies. And so if I resume share, can everyone see our polling questions right now? Yes, we can. Perfect, thanks, Angel. Okay, so thank you everyone for those responses. And so to start off with, to give a little bit of background, I think it's probably reasonable to hear for all of us that accommodating visitor policies for inpatients in hospitals have very positive impacts on both the patients as well as their family members. And so our visitors help to feed, mobilize, provide orientation and hygiene support for their loved ones. And that's a major part of the reason why by March of 2020, over 70% of the acute care institutions in Canada had very accommodating visitor policies. And so these were described as being able to visit anytime, they were open 24/7. And as a result, in the literature, we were seeing that there were greater rates of patient satisfaction, improved information sharing between the medical team and the patients and their families, better medication adherence, maintained cognitive function for the patients, as well as lower readmission rates to hospital. And so the definition of visitor that we'll be moving forward with during this discussion will really be around essential visitors or essential care partners. And so those are individuals who, beyond just providing social visitation, really address the patient's fundamental care needs. They provide mental health and emotional support. They facilitate processes of patient care and patient flow, as well as discharge from hospital. And so the term that we use more commonly now is essential care partner. And then, of course, we're all aware that in March of 2020, Ontario enacted a state of emergency because of the COVID pandemic. And 2 days later at that time, our then Chief Medical Officer of Health, Dr. David Williams, released guidance that suggested that in order to ensure a safe and secure hospital environment, that we restrict the number of visitors who are allowed in hospital. And so the main reasons behind these restrictions were to preserve PPE for hospital staff, as well as to reduce the potential of transmission of COVID from outside and within the hospital. And as a result, the Toronto Region COVID-19 Hospital Operations Table got together to release guidance that recommended visitor restrictions with certain exceptions in hospital. The first iteration of this guideline was released in March of 2020 on the 20th, so just a few days after the recommendation from the province moved forward. And so on the left-hand side here, you'll see what that initial version of the policy looked like. It's not the entire thing, but it does give you some sense of the principles and values on which the initial visitor restrictions were recommended. And so some of those values were proportionality, stewardship of resources, ensuring that we were acting in the patient's best interest. And so this guidance was very iterative. In November, the next version was released that reflected the phased approach to the pandemic that the CDC was taking. And so in this next slide here, we'll see that our phases of visitor restrictions were mapped onto certain phases of the pandemic itself, with phase 1 being the most restrictive and phase 4 being the most liberal. And the question that drove myself and our team to wondering was whether the development and implementation of this visitor policy was fair and ethically sound. So that was our primary guiding question. And as a secondary one, we wondered whether by studying this policy, we could learn any lessons that could inform its future iterations. So we decided to use an accountability for reasonableness framework to assess the development and implementation of the policy. And so for those of you who may be familiar with this is a very common bioethical framework that was initially developed to guide healthcare priority setting decisions in context. And so it really is a process of evaluating whether decision-making was fair. There are 4 principles that it's based on: relevance, publicity, revisions and appeals, as well as enforcement. And so the definitions of these are: for relevance, we want to ensure that the rationales for priority setting rest on reasons that stakeholders in that context can agree are relevant. For publicity, we want to ensure that these decisions and their rationales are publicly accessible and communicated. There must be a process for revising and appealing the decisions made as a result of any policy or guideline. And for enforcement, leaders who are decision makers in the priority setting context are responsible for ensuring that those first 3 conditions are met. And so the methodology that we used to study this guideline and policy was a qualitative quality improvement approach. And we used the consolidated criteria for reporting qualitative research guidelines to guide our work. We did receive an exemption from the U of T Health Sciences REB. We developed first a semi-structured interview guide according to the accountability for reasonableness principles. And we first piloted our questionnaire with a member of the table for their feedback and further iterating. For our participants list, we used a combination of purposive and snowball sampling and approached developers and implementers of the policy across all 6 institutions of the Toronto Region table. And we received our participants' verbal consent for audio recording. And to analyze the data that we got from the interviews, we used a process of content analysis. And so we deductively coded for our accountability for reasonableness themes, and then went through our transcripts again to inductively code for any recurring themes that might come up spontaneously from our responses. We also maintained a color-coded audit trail to help ensure that our results were replicable. And so in total, we conducted 9 interviews that were approximately 30 minutes each between March and May of 2021. And so that's a full year after the policy was first implemented. And we did have all of the table institutions represented amongst respondents. Here's a breakdown of the respondents that we had and their titles. What was interesting about this was that there was a lot of overlap between the respondents that we did have. And so, for instance, there were developers that also served as implementers of the policy, or implementers that were also patient and family partners, for instance. And so after we reviewed our transcripts, this is our coding tree, or an example of what we did. And so we did our data collection and we did our interviews using our standardized question guide. We went through an initial process of analysis and iterative content analysis. We then identified particular codes. And so here's an example here where we would read a transcript and identify a particular word code. For instance, if someone mentioned the word marginalized, that code would be clustered with codes that were related to it. For instance, disadvantage, social determinants, or impairment. And those codes would be used and clustered to create a category overall of equity, which would be categorized and clustered with related categories such as advocacy to create ultimate themes. And so for anyone who has done qualitative research, I'm sure coding trees will be very familiar territory to you. We ultimately ended up with 11 categories and 7 overarching themes. So to break down some of our most prominent results, we'll first go through each of the A4R principles. So with respect to relevance, there was actually quite a lot of agreement between our respondents here, where we found that there was consensus that all of the organizations adapted the table's policy for use at their institution, and that there was very broad consensus that the ethical principles on which the policy was based were aligned between institutions and were appropriate to the situation. And so one representative quote was that we agree our organizations should have very similar policies. This should be a region-wide agreement in Toronto. Our policy was very close to the original document developed, and any changes would have just been specific to our organization's language and how we write documents, as well as narrowing it down to key points. And so that was from a developer of the policy at one of the table institutions. With respect to publicity, so we found that the policy was actively communicated to patients and their family members through frontline staff directly communicating it. There were letters that were provided on meal trays in various languages to patients. Phone calls were made to family by frontline staff. Entry screeners were also responsible for making sure patients and family members were aware of the restrictions in place. And patient relations also had a key role to play in communicating the policy. In all of the institutions that were involved in the region table, there was a patient-facing version of the policy on website, again, available in numerous languages. And where it became really interesting was that staff expressed that they were overwhelmed, distressed, or emotionally exhausted by having to communicate the policy, and that they were noticing that there were significant consequences for patient care as a result of needing to restrict the number of visitors that they had throughout the day. And so one quote that was particularly striking to me in this theme was one of our developers who said, "We had 24/7 visiting prior to COVID. So for us, it was a huge adjustment, and our staff were quite angry that there were no visitors. For example, a wandering patient with dementia who lives with their daughter can't recognize the sitter who's with them in hospital. And when they're being combative, they just need their daughter there." I think that theme of healthcare workers, and particularly of frontline staff, as well as their hospital administrators, feeling that pressure of wanting to ensure that there were visitors in hospital, there was a significant amount of tension between that and wanting to keep the hospital workers as well as patients and their family members safe. And that was definitely a theme that resonated throughout all of the interviews that we held. With respect to the appeal process, so we found that all organizations had an appeal mechanism by which family members could appeal the decision to not allow their particular family member or loved one a visitor. These appeals decisions were mediated by multidisciplinary committees with patient and family partner involvement. And the way that the appeals process was communicated was that they were available on the hospital web pages and they were communicated at first contact. And so we were told that if a patient was denied a visitor for whatever reason, the individual notifying them of that would be responsible for ensuring that they were aware an appeals mechanism existed, and that through the appeals process and hospital committees working through the appeals they got, they really drove policy change in that reflecting on a particular patient consideration or situation really prompted hospital administrators to reflect on whether they needed to modify aspects of the policy to reflect considerations that they maybe hadn't thought about before. And so from one of our patient and family partners, they mentioned that there was a lost opportunity for families, especially of those who died. a video call at the end is not the same as being present, and the appeals process led us to realize we needed to not just look at the medical perspective, but also the humanity of our family members. With respect to enforcing the policy, this was described in that the hospital committees would incorporate feedback from the appeals, feedback from frontline staff, as well as different phases of the pandemic into iterating what the policy looked like, and that this was really a continuous consultation and multidisciplinary process. And so one of our developers mentioned that the evidence kept evolving through the year and we kept adopting it. We took continuous iterative opportunities to make it better, not just because the phases were changing, but because we had the underlying belief that we needed to continue to refine and make this policy better. Another developer mentioned that having one person at the bedside and families standing outside the window was gut-wrenching. And so reflecting on small stories like that really drove policy change. So with respect to our inductively derived themes, there were a number of themes that our respondents brought up spontaneously. The first one that really stood out to us was that they noticed that those patients who were unable to advocate for themselves were particularly disadvantaged by the policy. And so a number of respondents reflected on equity considerations. In particular, marginalized groups were thought less likely to be accounted for by the policy, to be able to understand the visitor restrictions that were in place, as well as to be able to access the appeals process. One of our implementers of the policy noted that we've been struggling with equity considerations and whether there's justification for trying to take into account the social determinants. Some aspects of disability are reflected in our framework, but other kinds of identities that may justify more visits or exceptions are not reflected. Another recurring theme was that there was fairly significant inter and intra-hospital variation in policy enactment, and that was one of the words that came up. Was the idea in our initial polling that there was a differing amount of restriction depending on where you might have been in the hospital. And that was certainly true of the responses that we received as well, where some respondents noted that depending on which unit or hospital you were in, the policy was applied more or less leniently. And this was attributed to factors such as the ways that the language between staff and family were interpreted, the discretion of the staff that were on call to make these decisions, the values of staff and hospital leadership, as well as differences between the in-unit or organizational level culture. So one of our developers reflected that some areas of the hospital were not as open to visitors and would be quite restricted, and others were the opposite, which was difficult because it created tensions based on where someone was in the hospital. Something that came up in their discussions was how consistent the policy should be applied across the organization or whether it should be the same everywhere. And finally, another recurring theme was that there were definite unaccounted costs in implementing visitor restrictions like this. And so most of our respondents noted that the policy couldn't account for unintended harms to patients, such as lost time, capacity, or impaired recovery, and that there was uncertainty around the risk of visitors who were actually, who may or may not have been transmitting the disease in hospital. And one of the most poignant quotes that I think we've encountered was this one here, where this individual noted that they'd had one outbreak on a palliative care floor and unfortunately 2 patients died. In the end, the thought was that they died because of their disease process and they were in the last few days of life anyway. But was it because of the family who visited? They didn't know. And so these were the conversations we were having. Another developer mentioned that there was a patient with Parkinson's whose ability to do simple things like hold her grandson, read him a story, or have him on her lap would decline. Her comment was that he was never going to be an essential care partner at the age of 4, but how does anyone ever give the patient back that lost time? And so in thinking through the analysis of our transcripts and our project overall and what we've gleaned, some of what we'll note is that overall, the policy in the way that it was developed and written did abide by the principles of accountability for reasonableness. And so we can conclude that it resulted from a fair decision-making process. What we learned and heard from respondents, though, was that a policy is just words on paper. and that there was pretty variable application of what that policy looked like, which could have led to inequitable access, particularly for patients who weren't aware of how to advocate for themselves or families who were not aware of how they could advocate for their loved ones in hospital. There were also noted to be opportunity costs to patients that were unmeasured. And so really we're not able to appreciate the full scope of the harms that are done to patients or their families as a result of implementing these visitor restrictions. And what came up time and time again was that COVID disproportionately impacts marginalized groups, as does the visitor policy. And so in building a policy like the one that we had, could we have been reinforcing structures of privilege that favored folks who were able to advocate for themselves and know how to access appeals, for instance, when others might not be able to? So thinking about some of the strengths of the work that we've done, this does, so far as we know, represent the first quality improvement assessment of a COVID visitor policy in Canada. And we received broad representation from all of the involved institutions. And there was general consensus that the principles of accountability for reasonableness were met in the policy development and implementation. Some of the limitations of our work are that there was certainly a risk of bias because we interviewed developers of the policy. And there was a focus exclusively on academic institutions, which means that the generalizability of our results is quite limited. As well, we did only have one formal patient and family partner participant. And so future directions in which to take this work, what we've passed back to the Toronto Region table is that certainly equity implications should be considered from policy design through to its application. That there's a need to determine the appropriate metrics through which we can measure undue harm posed to patients from visitor restrictions. That we need to quantify the frequency of outbreaks that can be traced back to liberal visitor policies. And that moving forward, hopefully, we should need to develop a nuanced approach for reintegrating visitors into the new normal. Before moving forward from there, I wanted to discuss my personal connection to this work. And so this is a photo of my grandfather on the left here, who was admitted to hospital during the first wave of COVID from his long-term care institution. And he ultimately passed away because of COVID. And so as a family member, I was subject to understanding and trying to navigate one of the visitor policies myself. And so he really was someone who inspired my trying to understand whether policies like this are able to be fair and equitable for patients involved, because certainly he would be someone who would be disadvantaged by the policy as someone who did not speak a fair share of English and would not have been able to advocate for himself. And so that's the end of my formal presentation, but what I'd be really interested to hear from our audience members would be your experiences with visitor policies that you've come across, what you think was done well about the policy, what you think could have been improved, and what you think might have been principles that were missed in either the development or implementation of the policy. With that, I will open it up to any questions or comments.
Thanks so much, Vivian. And I think maybe I can just start and express my condolences for the loss of your grandfather. I'm sure I can extend that on behalf of our audience today as well. So I really appreciate you bringing this topic to the JCB for discussion. Visitor policies, I think it's been one of the things a lot of people, patients, families, and staff at the front line, administrators have really struggled with lots of ways over the pandemic. And as we've seen the waves kind of come and go, and restrictions have changed and policies have changed, there's been a lot of confusion, a lot of harm, and then also probably a lot of prevented harm as well at the same time. So it's complicated, and I appreciate the space today to think more carefully about it and think about the ethical principles and values and arguments in behind the development and implementation of the policies. So just wanted to start by saying thank you. So I'm going to let our audience know. So for the questions, if you have any questions or comments, we'd love to hear your responses to these questions that Vivian has posed as well. You can type them into the chat on YouTube. If you're not logged into YouTube, what you can do, or if you prefer also to send a question or response anonymously, You can send an email to jcb.ea@utoronto.ca, and we can add those to our question list as well. Maybe I can get us started with just a clarification question. So the timeline you mentioned, Vivian, for the QI work that you did was sort of over, started in 2020, and I think did it go till 2021, was that right?
Yes, and so the time during which we were evaluating the policy would have been approximately 1 year after the first version of the policy was released.
Okay. And I'm curious, how much did the policy change during that time? I know at our hospital, we had a lot of policy revisions over the last few years. So I'm wondering how much it changed and whether there are the changes or maybe the time at which the interviews were conducted in relation to the pandemic situation in those moments or the version of the policy, if you think it impacted the responses in any way.
So I would say that even if you, and maybe I can flip back to that slide there, between, oh, that's going the wrong way. Okay. Okay, and so on the left is that first iteration of the policy, and this was in response to when the province had released their guideline around visitor restrictions. And so at this time, it was essentially more of a guideline stating this is why visitor restrictions are necessary at this time. And here is some guidance as to how you might be able to implement this at your particular hospital. Certainly, I think the biggest change that we've seen since then is probably just moving to this phased iteration of the policy. And so all of the subsequent versions that I've seen so far have some variation on these pandemic phases. Where we see here, when the CDC released their pandemic phases and we were able to map on our visitor policies and how they would correspond, I feel like since then, the changes that have been released have really been, okay, what phase are we in? Do we need to make adaptations to this particular phase and in this particular moment of the pandemic? Beyond that, I think there have been more equity considerations built in as time has gone on. And I suspect that's probably in response to the feedback that we're getting through our appeals processes and through our frontline staff. Where now I believe in the Toronto Region Hospital policy, there is a particular consideration for Indigenous patients, for instance, which wasn't present at the beginning of the pandemic. And so I would hope that we could continue to iterate it in addition to the phases of the pandemic itself, also taking into further consideration, how do we break down patient groups so that we're really making sure that we're addressing all of the potential considerations that can come up. And I think that's something that was done particularly well, was really making sure that that feedback from frontline staff and from hospital admin was taken into consideration with subsequent iterations.
Thank you so much. So another question that we have from our audience is if you have, you can say a bit more about the extent to which some of the equity related concerns have been anticipated and addressed with greater attention to the process by which the policy was developed in the first place. So for example, they say later versions of A4R include an empowerment principle, which draws attention to inclusiveness in the policy process.
Sorry, I just missed that last part, Angel.
Oh, so the last part was, so as an example, they're wondering, so in the accountability for reasonableness frameworks, some of the most recent versions of those frameworks include another criteria, another principle that is the empowerment principle, and it draws attention to inclusiveness. So that policy development implementation needs to be inclusive in the process. If you can sort of speak to whether or how that might have anticipated or addressed some of the equity related concerns that have come up around visitation.
Got it. Okay. And so if I'm interpreting this question correctly, if we think back to the initial policy that we'd had, and I'm not sure it's captured in my screenshots here, but the way that it was broken down was into different patient categories. And so how it happened was at the Toronto Region table, so far as my understanding goes, there were different patient categories delineated that would need particular considerations. And so a couple of them are shown here where we see end of life, childbirth, major surgery. And so it's really, I think, with these patient categories where we can build in inclusiveness a little bit better than initially it was done. And so, as we mentioned, now being an Indigenous patient is a category of its own where it wasn't before. I would say that there wasn't too much of a development with respect to further parsing these categories out over the phases of the pandemic, but with respect to patient or visitor allowances between patient categories, those may have changed slightly. If we were to go back and redevelop this policy or think about it from the ground up, one of the findings that I think is really important from our work is just that there, for instance, was one of the quotes from our developers saying, we weren't sure how much to build in those social determinants. We weren't sure how much to consider that. And so in addition to making sure that we have a diverse group of patient and family partners who are sitting around the table, I think it's really making sure that we're casting our net broadly. And so one way that it seems that these patient categories were approached was just looking at the different units in hospital. So labor and delivery, for instance, surgery, palliative care. But moving beyond that, a different step that we could take is looking at the demographic in the general population and who's represented and reflected in our hospitals. So for instance, is it a language distribution that we need to think a little bit more about? Is it a cultural background that we need to cater to a little bit more? And so beyond just thinking about the units that we have in hospital, who is the demographic that our hospital is catering to, whether it's in a particular city or particular neighborhood, and how do we best address those needs broadly? And I think that would be probably a good place to start.
Thank you so much. So we have another question here, and it's from Rebecca Greenberg, and she's asking, so she says she's interested in hearing from folks who are involved in essential care partner policies, including how their policies were iterated and the biggest learnings. So I think that question might be both for you and the audience, but maybe I'll add as well. I'm interested in whether you have any thoughts on the sort of creation of this essential care partner sort of designation. One of the things that I've thought about is just in terms of, so it's sort of create these two tiers of visitation, right? And insofar as the patient gets to choose who the people they want there, who those people are. So I don't know, so I'm curious about how much work you think it's doing when they're called an essential care partner versus just the person or people that patient has chosen to be their sort of their visitors most of the time or more of the time. So if you have, so just to sort of recap, if you have any thoughts, suggestions around the essential care partner policies in particular, and then what you think of that designation as well.
I would actually love to hear from the audience what they think. And I think that was the question that Becky initially posed.
I think so. Yeah, we've got Lori and Terry moderating the chat. So as they come in, if you can, I'll just ask Lori and Terry if you can drop them in right under that question in our list, and then we can come back to those as they come up. We'll go to the next question. I'll pause and we'll go to the next one. So the next question is from Jane Midas. She says that you said that the creation of the policy was fair, yet it doesn't seem to have taken into consideration any effect on patients other than possible COVID transmission. This was changed later, but this wasn't fundamental. But wasn't this a fundamental flaw on the policies initially?
Yeah, and so the way that the policy was developed was really the main goal initially was to ensure both PPE conservation as well as reducing transmission in hospital. And so I would agree that as much as initially the policy attempted to ensure fairness as one of its founding principles, definitely there were a lot of undue harms posed to patients that were not initially accounted for. And so what accountability for reasonableness allows us to say is that the development and the process that the policy went through was fair, but it doesn't really necessarily talk or speak to the outcome of what the policy ultimately was. And that's an important distinction, I think, to make. So like we had explored through the results of this work, absolutely, there were undue harms to patients that I think we're still not able to measure in full, probably because restrictions like this have not been implemented for such a long time or for such a long duration prior. And so there just wasn't a precedent on which we could base the decision making that led to policy like this. So absolutely, I agree. There was definitely harm to patients that we need to do a better job at qualifying.
I'm curious, do you have a sense of how often the appeal process was tapped into, or which type of patients were able to, or family members were able to follow through with that appeal process?
So the sense that I got from the responses we received was that it did depend hospital to hospital, as well as sometimes unit to unit as well. Something that struck me about reflections on the appeals process was that there were certain groups of patients who were better able to access that, whether because they were English speaking, for instance, whether because they knew their way around patient relations a little bit better than the average person. So there was definitely a group of patients who were better poised to advocate for themselves and their family members. And I think that is a shortcoming of the appeals process for sure, where the thinking needs to be around who isn't able to tap into this, and how do we make this process easier to access for everyone across the board.
So I'm looking at our comment sheet here, and I see that we've got one response to that earlier question around essential care partners. So Carol Ann says that if Toronto Region had included many more patients or essential care partners from various sectors, the policies themselves would have been more inclusive. I think that speaks to sort of some of the comments you made earlier in your presentation, Vivian, that really, I think you had one family or essential care partner representative in your quality improvement work, but also that I think what a lot of people have noticed sort of the opportunities to better engage patients and their families in that process.
Yeah, absolutely agree. And the thing that I'll add to that is ensuring that we have broad representation even amongst patient and family partners, because certainly representing one demographic group still means that there are a lot of them that maybe we don't consider. And we should also be thinking about who becomes a patient and family partner and how are those processes, how are they recruited? Are they really representative of all of the patients or a certain group of them too? So absolutely agreed.
Move on to the next question here. We have a question from Andrew. He says, thank you for tackling this. Restrictive visitor policies have failed to respond to the increasing availability of PPE and remain unsupported by evidence, neither of which suggests that their contemporary application satisfies A4R, in particular the principles around transparency and revision. Did any of your interviewers reflect on what the end game is for such limitations in the face of increasing awareness of past and continued trauma stemming from the implementation of these policies?
Sorry, so the specific question was, did our interviews...
I can drop it in the chat too. So it was a big question. So I've just done that, no problem. I'll give you a second to have a look.
So that's a great question. I would say that the last interview that we conducted, now we are in January of 2022, would have been about over 6 months ago. And so I think we're constantly gaining more information about the appeals processes, as well as how the policies play out in hospital. So I suspect that there's probably been some movement here that I may not even have been aware of in the interim. The last that I'd heard from our set of interviews conducted was that there were fairly reasonable policy changes that were made as a result of appeals. But I wonder actually if Becky, you might be able to speak to that if you're still on the line as someone who's more acquainted with the policy in its current iteration.
So maybe I'll just add to Andrew's point, in particular around the PPE. I'm curious if any of the interviewers commented on the sort of changing circumstances around PPE. I know when the pandemic started, there were concerns about supply. And as the pandemic has evolved and there's been more evidence to show that COVID is airborne, and better masks and better fitting masks, respirators are sort of, they do a good job of reducing the spread. I'm curious if any of the interviewers shared any thoughts around sort of that dynamic between the sort of evolution of awareness and availability around PPE and what visitor policies were restricting or allowing for, and whether they were responsive to the changes.
That's a great question. I can't say that it came up at the time that we were interviewing. And so I would be really curious to go back now and ask of our interviewees what they think. But I believe at the time, putting myself back in those shoes, PPE was still a consideration in terms of shortages and making sure that there was enough supply. And so certainly a lot has changed for sure.
We do have a comment from Harvey, and maybe I'll add a question to it as well. So Harvey says this is a good study, and but it's a repeat of some of the learnings from 2003 as a result of the SARS restrictions of visitor policy restrictions at that time. So I'm curious, if you are aware of sort of that work from SARS, or even just imagining sort of that, you know, still finding similar sorts of things around, I'm presuming, the harms and some benefits around visitor policies. If you have any thoughts around or going forward, right? If not much has changed since then, if you could say a little bit more about your work going forward and some of the things that you hope to see.
Right. And so what I think is really interesting when we compare to SARS is the transmissibility of the virus and the number of waves that we've now experienced. With SARS, it was more of a self-limiting pandemic than we have now experienced. And so we are now 2 years deep and unfortunately still going. And so we certainly, I think, have opportunities to learn from what we know. But what makes it difficult is with successive variants that we're seeing, it becomes hard to know where specifically the situation will go. And right now, for many hospitals, we're back in phase 2A because of how transmissible Omicron is. And so I feel like every time we feel as though we're getting on top of the pandemic, there will be an evolution of the situation that would, I think, necessitate more caution than might be necessary in hindsight. And so that might be part of what makes it so difficult to strike a balance between a liberal visitor policy and one that is cautious and makes sure that we're protecting our patients and family as best we can, just because of how much we don't know. And so how much we should be doing within that time, I think, is a matter of debate. But I would absolutely be in agreement that there are so many harms to patients that we might not see and that we could probably better account for in successive versions of the policy.
So another question we have is whether you know of any other research, and I know you said this is the first quality improvement work sort of on this topic here, but anything around visitation that brings forward more of a patient or family perspective. You're aware of any work that has happened or maybe that's in progress?
Yes, there is a group, I believe, out west who is looking specifically at patient and family experiences of visitor policies. And so I think they're hoping to sit down specifically with anyone who might have been impacted. I believe their work is still ongoing as of the last that I'd heard.
I think we have a follow-up question regarding the SARS visitor policy comment. And I think you've answered a little bit of this already, but I wanted to pose it in case there's anything you want to add. So Carol Ann is asking, how will this study, so your study, influence future visitor restriction policies, especially since taking into consideration that some research from the SARS visitor policy was similar? So you want to speak a bit more, if there's anything you want to add about the impact for future policy development or implementation? Yeah,
and so the results of this work have been fed back to the Toronto Regional Hospital's table that we spoke about before. And so I'm hoping that at least in context, it will be something to reflect on with respect to the discussion that we reviewed. moving forward, I think the limitation of our work is how generalizable it can be. And so our work was based around 6 academic and tertiary care centers in Toronto. And so do the policies implemented at these hospitals necessarily reflect or align with those in other parts of the province or country? It becomes really difficult to say. And so I think probably what's best would be for this work and its lessons to be applicable to academic institutions in future, hopefully. And I would hope that it informs successive phases of the pandemic that we're still in.
Great, thank you. So we have a question from Lynn, and she's asking how have pandemic visitor policies shifted conversations around home care and a move towards more outpatient medicine?
And Lynn, do we mean in the context of COVID or more broadly? Because home care is a whole other topic for sure.
I think in the context of a pandemic.
Got it.
Yeah.
Well, I mean, I think it is no surprise to any of us that our home care resources are severely constrained, even at the best of times. And then during the pandemic, as a healthcare provider, I mean, it's been near impossible to access. And I think that doesn't come as a surprise to any of us. Do I think it would be fantastic if we had more supports and funding in that way? Absolutely. Do I necessarily see that happening currently? Not in particular. I suspect it should be a long-term priority, but for now, unfortunately, I think the state of home care, as difficult as it is, I don't anticipate that it would change in the near future, given we are still under such severe occupancy pressures in hospital.
Thanks, Vivian. That's helpful. And Lynn specified that she, her question related to either or, right? So both pandemic or non-pandemic circumstances. And I think you spoke to both of those as well. But we do have a couple comments from Rebecca that I'll read out and see if there's anything that you wanted to add. She says, with respect to PPE, it's only one measure. So even with PPE, there are transmission risks of having visitors in the building. And I guess on a separate point with respect to transparency, organizations were all asked to make policies transparent and publicly accessible. And the policy was iterated based on the nature of appeals and concerns raised from stakeholders. And so that was, I think, in a bit of a response to Andrew's question. So if you have any comments on sort of the limitations of PPE or sort of the ways in which visitor policies were made transparent and communicated, or on the accessibility or sort of responsiveness of those policies. Throw back to you, Vivian, in case you have anything to add.
I don't have anything further to add.
Okay, and we have one comment that's anonymous. I'll read it out, and I think after that we'll have time for one more question. So someone says, I'm a long-term healthcare provider with nearly 40 years of experience. The harm of restrictive visiting policies far exceeded any benefit. There was long-standing evidence it should have been used to ensure holistic, empathetic, and ethical approach to visiting. They say this is not the first viral outbreak in recent history. Hospital policies, I guess they say to follow fear-mongering measures instead of ethics and evidence. So I guess there's some disagreement about evidence there. And they said there's an importance to demand accountability and remembering really the people who suffered and died and lost family alone. So they're really calling for the importance of accountability. I'm wondering if there's anything you'd like to say in response or in addition to that comment.
I think my one reflection on that would be, there was that comment that was made by an implementer who noted that there had been an outbreak in their unit. And as a result, there were 2 palliative care patients who passed away as a result. And so part of the discussion that their team was having was, could that outbreak have been related to having visitors on the floor? And I think putting myself in that capacity, it becomes really difficult to strike what can seem an appropriate balance, because having made the decision to allow visitors, you are taking on a risk, and it becomes difficult to know whether it was a result of your decision in allowing visitors in that these patient deaths happened. And I think that can certainly weigh on hospital administration, on frontline staff, on anyone who has been in this situation. As a result, to take very seriously and try and be very cautious about how the policies are developed. And I think that that in part is what's really interesting about trying to find the right balance here, is balancing those potential risks and needing to bear those risks against the known patient harms that are caused. And I certainly am not someone who has a solution to that issue, but that point and comment is well taken.
And the last question we had, and was really just if are there any sort of final thoughts, final takeaways that you'd like to leave the audience with today?
I think as a family member and as a frontline worker, having interacted with these policies in numerous different ways, you can understand the tensions on both sides that drive both individuals to think that they are not necessary and are more restrictive than they need to be, as well as the risks that are borne by those who are developing and implementing the policy. And so I know it's a very middling answer, but I think it is reassuring to me to understand that the appeals are taken seriously and that the policy is iterated. And we might not strike an appropriate balance, but hopefully we continue to work towards it with the information and the evidence we have.
Thank you so much, Vivian. Unfortunately, it's we're almost at 5 o'clock, so it's time to draw our seminar today to a close. And then before we do, I just have a couple announcements before I thank Vivian. So our next seminar will take place next week on Wednesday, January 26th. Jordan Wadden will be discussing advanced artificial intelligence in healthcare. Is consent really in jeopardy? And to sign up to receive our weekly seminar reminder emails, please send an email to jcb.info@utoronto.ca. And for the CSB students enrolled in the CSB Student Seminar course, please remember to keep track of your attendance. And last but certainly not least, Vivian, on behalf of all of us here today, thank you very much for your presentation. I really enjoyed it, and it's an important topic and timely, and we appreciate your time. Thank you.
Thank you so much, Angel, and thank you everyone for your engagement. I really appreciated being able to speak with you.